Welcome everybody. Thank you for participation. This is the first of our second, turn of our committee, our skull-based committee of the World Federation, and we are going to try something new where we have participation of people and neurosurgeons from all over the world that send us cases that are intriguing or cases that they're having difficulties to manage in their countries. And our plan is to discuss and try to bring reality, particularly like difficulties that can be encountered in different scenarios. And we will bring all that in consideration in our discussion. So today here, we have Dr. Suichi from Oya from Japan, Dr. Muto from Japan, Linda B. from US, myself from US, David Rojtowski from South Africa, Francisco Guzman from Colombia, and we have two special participants that sent us the cases. We have Dr. Dusi Kong from South Korea, as well as my co-chair. We'll discuss these cases, and I'd like to not waste too much time and start with Dr. Izaki Kim. Dr. Kim is from São Paulo, and he is interested in skull base and pediatric neurosurgery, and he will share his screen and start with the first case. So Izaki, please be quick with the main points that you would like to discuss, because then we have time to discussion. Thanks so much. Please.
Thank you. Thank you, Dr. Provadello. Thank you, everyone. Good morning. My name is Izaki Kim. I would like to present the case today this morning. Is a female from 49 years old from São Paulo. She had no occupation and the education was until high school. She had headaches for 2 weeks, and the patient refers that the beginning of symptoms with the symptoms started with a progressive visual field loss over a year, like a tunnel vision, and started to complain of headaches associated with nausea, vomits, and confusion 2 years prior to the admission. Pathologic and previous pathologies, she had dyslipidemia and used simvastatin. She had no issues with general medical exams, but in the neurological medical exam, she had loss of points in the Glasgow Coma scale. She had a visual field of 20 out of 50 in the right eye and 20 out of 30 of the left eye. She had bitemporal hemianopsia, and she had papilledema as well. So when she arrived, was performed a CAT scan in which we could see big mass in the cellular and supracellular area, and we could also see the hydrocephalus. So at the time we performed, it was chosen to perform a contrast exam as well. And at that moment, the team chose to perform a VP shunt guided with endoscopy with septostomy.
Yeah. So, Isaac, let's stop here for a second just to see what people would do in this situation. You know, like Sami, did you see the presentation? What do you think if you get a patient arriving like this and you got a call from your resident? What do you think is first thing to do?
I think an EVD would be something to do just to temporize this hydrocephalus and get an MRI. I didn't catch the first 2 minutes, but
yeah, patient with the bitemporal hemianopsia, basically in confusion.
Yeah, I would put an EVD for sure. Drop an EVD, not a shunt. Then see what that is. I mean, angioma, it looks like it, or clinopharyngioma on the MRI, and then.
The idea here is there's no right and wrong, but it will be interesting to see the different perspectives. So in different countries, I think I do see the possibility of just putting a shunt, but some people would argue that if you take the tumor out and having an EVD to temporize, perhaps you can avoid that shunt. What do you think, Francisco, in Colombia?
Good morning, everybody. If we have patient with this hydrocephalus, but the patient is in Glasgow 15, we wait and we take the tumor out. But in this case, the Isaki is the name, don't you? Isaki. He told us that in Glasgow is 13, so the patient is not good condition. So I think have a external shunt could be a good advice, in my opinion.
Yeah, it's very interesting how this can vary, right? The Dusik, what do you think? What would you do if this patient arrived there in Seoul at your hospital? You're muted, Dusik. You're muted, Dusik. We cannot hear you.
I'm
Go
sorry. If I were, and I think it's the first EVD, and then we're gonna wait for the consciousness of the patient, and we will have a schedule of second operations for tumor removal.
Okay.
Would you do a unilateral EVD, bilateral EVD, or try to just perforate the septum?
As if the unilateral EVDs, it will be okay, I think.
Yeah. So Linda, what do you think of this idea that Izaki, Dr. Kim and his team in São Paulo, they decided to put a shunt in with a septostomy there? What do you think about that?
I think it's something that certainly many people pursue, and it's a reasonable option, especially the septostomy, to make sure that that there is communication in both sides, given the obstruction at bilateral foramina Monroe. I think I personally probably more commonly put in an EVD as well in these situations and progress to surgery. But I think that depends on availability of the OR team and space and, the other parameters. But in a sick patient, diversion of CSF by any means.
Yeah, I'm going to bring, so the other reality that I've seen, I think to mention this to Sami, because I agree with you. I think in my reality, I'll put an EVD and try to do the surgery as soon as possible. And then after surgery, try to elevate the EVD and see if we can take it out and avoid the shunt. But I've seen the reality in some other countries, like where if you put an EVD, it's not until 3-4 weeks later that you can do the surgery. And with that reality, then an EVD will cause infection, will be more problematic. So then you jump into putting a shunt, because that way you keep that patient safe until you can do the surgery. So let's see what Dr. Kim has to say about that perspective.
So in our hospital, we couldn't, we have an issue with the MRI machine. It's outside of the hospital building. And as we saw the hydrocephalus, we considered an urgency and emergency otherwise. And if we wanted to put an EVD and take the patient to the MRI machine, the disease control of the hospital wouldn't actually allow the situation. That's why we chose to perform the shunt prior to going to the MRI. So it was a lot of discussion around if we should do a shunt or try to biopsy or even go into EVD. But at that time, the patient couldn't perform the MRI because we didn't have a scheduled time, and we have to compete with the outpatient patients as well in our hospital. So that's why we performed the shunt. But yeah, the team would agree at that time that we wanted to perform just an EVD and afterwards the resection of the tumor.
Yeah, I think this is thanks for bringing that up, Dr. Kim, because this is really the reason we are doing these discussions here, really to see the issues of the world. There's no right and wrong, depend on the perspective as well. And let's see what Dr. Sadir from India has to say about it.
So if you have a waiting time and you want to just take it out, then you just do a Omaya reservoir, which you can always tap and keep it like a continuous flow with a scalp set and do the procedure. And if you still require to drain the fluid initially post-op, if you're going through the nose, there's a leak, you can always drain it for 4-5 days, and that will also help you. Omaha reservoir is also an option.
Interesting. I would not think of Omaha. So can you explain, like, let's say you put an Omaha, then how?
So Omaha reservoir you place, you have a reservoir on top. You can put it on continuous drainage with a scalp vein set for 3 to 5 days and just take out the scalp vein set when you require. And once you've done a definite procedure, then the Omaha is still there. So if you have a post-op leak, you can drain every day some amount of fluid instead of doing a lumbar puncture. So that is also an option which can be tried. But I think going straightway for tumor excision is a much better option. But because we are considering emergency doing these things, that's why Omaha is also an option compared to a EVD.
How do you continuously drain an Omaha? That part I don't understand.
So we have a scalp vein set, which we used to, when 20, 30 years back, we still have them in our country. So you just put a Omaha needle through the skin and it forms a continuous drainage through that. So for our cases which are, yeah.
This is the trick from pediatric neurosurgery. It's when they have the Macomb reservoir for temporary for like instead of doing the ventriculostomy with a needle through the anterior fontanelle, so you put that, and oftentimes if you want to leave it continuous drainage, you get the butterfly.
Yeah, you can drain it
and just insert it there, and it has a guard that you can put it. It's like a cup. You put it on top and you tape it to the head, and have that butterfly line draining to an external drainage.
Wow, I see. So basically you puncture the reservoir and you drain.
No, reservoir is to be punctured. The membrane is like that. You can puncture it multiple times.
Right.
Right. No, I like that idea. I never thought about that. Thanks for sharing that, Sadir. Because that could have been an option for you, Dr. Kim. Like you put a Omaha and then you drain for
do a MRI and do the procedure.
And then to go to the MRI, you have a sealed area, go back and forth. That's interesting. Go ahead, Guzman.
Some advice for the past. In my country, like in the beginning of this century, where we used to do that, like Sami and state like punction with the butterfly. The problem with that punction is that you're going to increase and decrease the pressure of intraventricular, and it's going to cause hemorrhage into the patient very often. So,
I think the point here at Kim's hospital that they don't allow EVD to get to the MRI scanner. I think that's the whole difference of what you or I can do and his hospital, if I got that correctly, right?
Yeah, you're right.
Yeah, but my advice is that, it's not, it's an option in very low context countries, but it will cause hemorrhage in the intraventricular. I remember when I was a resident, some infants have hemorrhage with this kind of, you punction, you drain the liquid, then you're going to decrease, and it's going to decrease, it's going to cause hemorrhage. Then the patient is going to increase again the head. So it's an option, but I don't advise that much.
I would,
Pathology also makes a difference here because this is a pituitary adenoma that got apoplexy and acute hydrocephalus on top, or if something has some acute turn of events here as well.
Yeah. But Francisco, the reality is that everything can cause, you can have problems with a shunt or an EVD, so I don't think we can generalize with the butterfly. I think any intervention has potential for risk. So, but I love to hear from Sadir and Sami. This is a very interesting technique. So let's let Dr. Kim continue on what they did.
So afterwards, we could perform the MRI, and we could see one side of the ventricle being a little bit less inflated than the other. And the characteristics were of the pituitary adenoma with cellular and supracellular extension as a dumbbell shape. Do you guys want me to stop a little bit or continue the?
Yeah. Let's just look at the image as well here, and then see if we can probably start with Linda. Tell us your thoughts. now in the reality, what do you, in your reality, what would you do next?
Yeah, I agree. This looks like especially with the 1 year, I think, progressive symptoms, as you mentioned. So a more slowly evolving pituitary macroadenoma. Were hormone labs checked once the hydrocephalus was stabilized for this patient? I think you might be on mute again, Dr. Kim.
Oh, we have the hormones. It's, sorry, right here.
Yeah, prolactin level was normal.
Yes.
I see. So for some reason, this person had a baseline set of hormones 2 years ago. Is that right?
Actually, there's more context to the situation. I'll just after the VP shunt, the patient wanted to be discharged because of the COVID that were happening back on the days in 2020, and her ex-spouse was really afraid of getting COVID, so they are asked to be discharged from the hospital because of the situation, and afterwards she lost follow-up because her husband unfortunately died of COVID, and she didn't want to come back to the hospital, and she went back to the hospital with another situation in which she went to the ER referring visual loss, but no headaches at that time. So that is when we could perform the visual field, and we could see the documentation of the visual loss, also the CT scan for the sella, and right now a new MRI in 2022, 2023. And that's why we have a baseline of the 2020 when she came first to the hospital and where we could perform a baseline of the hormones, and afterwards she came with the symptoms of visual loss.
Interesting.
Very interesting, yeah.
So
A
the
very
shunt,
sad
you
situation.
cured her in terms of the death, in terms of the shunt, appropriately, especially in this case, if she was afraid for surgery. It's also interesting, and I guess we don't know the times that these labs were drawn, that cortisol of 0.9 when she first presented, which then seems a little bit higher. Was she started on cortisol replenishment, or that was just because of the timing of the draw, or is that?
It was just the timing. She didn't start any treatment back in the day.
It's amazing with the size like that, the gland is still working to produce cortisol, huh? It's incredible. Let's see, Lila, like in Ukraine, now you have this tumor here in Kyiv, and how is that? Give us a little insight, like how would you do this, like in Kyiv these days, you guys are going through a lot there. There's a war going on, and you have this in front of you there. Patient is going blind. Share with us a little bit of your thoughts.
Hello, everybody. We will do a transnasal approach. I think maybe transnasal transtubercle a little more extended because of tumor spreading anticellular, and in case if patient had no shunt, I think we might use lumbar drain. But in this case, when the shunt is already input, we will do extended transnasal endoscopic approach. And to my opinion, this tumor could be well enough suctionable for purely transnasal approach. I don't think this is any necessity to do some transcranial, some combined approach. If we will left some part of the tumor, we can use cabergoline agonist or we can use radiation, but to my opinion, this tumor could be well good removed via transnasal endoscopic approach. Of course, if the surgeon is skilled enough in the surgery. This is my opinion.
No, very good. And I just wonder.
And of course, sorry, I disrupted you. And of course, we have. This is better to use Doppler. Without Doppler, without intraoperative Doppler control, the surgery would be very high, very risky. Yes. So good equipment. You have to be experienced enough in the surgery and Doppler. But the tumor constitution consistency seems to be favorable for the surgery, to my opinion.
Can you just explain to us, because I think this is a concept that I learned in East Europe as well, which is to use a lumbar drain for these big cases. And I think in a lot of parts of the world, people think about pushing fluid or pressure through the lumbar drain to try to push the tumor down. But I noticed that I learned that if you have a lumbar drain, you actually open the brain and more space for you to work supracellularly. Is that what you mean, Lila, with the lumbar drain when you use it?
Yes, this is certainly what I meant, because sometimes when we have a soft tumor and we start to remove the soft tumor, the supracellular part can go down, and you will have no access enough to the antecellular part. And in this case, lumbar drain might be an option.
Right.
In our experience.
Yeah, I started using not too long ago, and I definitely learned in East Europe there this concept. So thanks for sharing that as well. So Francisco, what do you think? What would you do?
In my place, definitely I will do endonasal approach. I have a Doppler, but I feel the carotid is very, very straight, very in their place, and the anterior cerebral arteries are just moving forward. So I think the endonasal approach could be a very good option. We can do it better with a good result.
Okay. Let's see what Suichi thinks, because I know Suichi is a very famous microsurgeon and sometimes likes to do things craniotomy. Suichi, what do you think in Japan?
I'm not sure if I'm famous, but I would select the combined approach, endoscopic and the transcortical approach, because this tumor is thought to be the pit net. So what I fear most is the postoperative hemorrhage. So I'm careful about the constriction in the middle of the tumor. That will increase the risk of the residual tumor through the single approach, like a transcortical or transcranial or endoscopic approach. So to remove the whole tumor to minimize the risk of a postoperative hemorrhage, I think that I would choose the combined approach.
And when you say transcortical, is like transventricular as well, Switch? Transcortical.
Well, I would. I would prefer the transcortical through the right frontal lobe. It's a simple approach. Yeah.
Okay, but through the brain or through the cistern?
Well, through the brain.
Okay, like a transcortical per se.
Yeah, transcortical. Yeah.
Trans right frontal lobe. Okay.
It's quite safe. Yeah.
I understand. Yeah, I've done one of those that I actually use a port through the brain to get the upper part of a pituitary adenoma, but not on the same surgery. I use it in a second stage.
So when you say
you use a port?
Go ahead, Sami.
Yeah, when you say transcortical, transfrontal, this is a pituitary adenoma, so the entire optic apparatus will be stretched paper thin on top of this tumor. And why not considering coming through transcallosal, for example? The tumor is pointing, lifting both fornices up. And if you do transcallosal, then you're avoiding the optic chiasm and the optic tracts and nerves being stretched on top of this tumor. I mean, we all remember when we used to do these cases more transcranial, and you go in for something that did not come down after a transnasal, and the entire optic chiasm looks like tumor capsule. So when you go transcortical, I think that's going to be a little challenging.
Yes.
How the transventricular approach is from through the foramen of Mollo, and with the endoscope, it's like the endoport surgery, and to remove the third ventricle tumors, and then combined with endonasal approaches.
It just gives you a small trajectory or a small corridor to work within. But yeah, I mean, transcortical, like a colloid cyst, you mean approach. So you're not going subfrontal or going.
Right, I think it's transcortical, transventricular that you meant. Yeah.
Sorry, may we have a sagittal view? A
Have a
sagittal
sagittal
view
view,
of the
Isaac?
tumor?
Right there. See, this is the goes a little. There's a component in front of the ACOM and a component in the third ventricle, basically. Like, so it's definitely very complex. I'll tell you how I do this. I go endonasal, and I remove like Lila as much as possible. Hopefully everything. My reality is that I do have intraoperative MRI available. So these pituitary adenomas that spill into the subarachnoid space or into the third ventricle. I then do, before waking up the patient, I do an intraoperative MRI. If I'm satisfied with the resection, I wake up the patient. If I'm not satisfied with the resection, like Suichi mentioned, I'm afraid of postoperative apoplexy, and then I would do a craniotomy, whatever makes sense for the residual tumor, because I'm looking at the MRI post-op, and then we will do a craniotomy. I actually done one situation like that 2 months ago that I had to do a craniotomy. And in that case, I came more like a Sylvian fissure to get the rest of the tumor because it was spilling laterally, like a regular terional. But I have another one that I've done in the past that I put a port through the ventricle because the residual that apoplectic was in the ventricle. And my recommendation is the sooner you do that, the better, because you don't want that to expand and suffer like hemorrhage, like Suichi mentioned. And then, so since we're almost at the 30 minutes here for one case, I would like to invite Dr. Kim to finalize, and then we can move to the next case.
You want? Should
What
I?
did you do? What did you do? I think you have a continuation there, right?
Yes. So we discussed the approaches and we did the combined approach. We went through endonasal first, and afterwards we did a transcallosal approach, and with the patient still sleeping. So firstly, the team went endonasal and tried to resect the most that we could, and there was some difficulties to go to the third ventricle, even though we had a 45-degree scope and we tried to reach further. Because of the limitation, we used the nasoseptal flap closed, and afterwards we did a transcallosal approach to remove the remaining tumor. And as Dr. Switch said, there were a little bit already of apoplexy going on, and we could see a little bit of bleeding already. So it had a good resection afterwards, and the patient was discharged 5 days afterwards with no leakage. It was an interesting case. If you guys would like to see, I have the videos as well, but I think that we should, if needed, we could go to the next case if Dr. Provadello would like to.
Yeah, I think probably based on the timing, we can share later if we have time. Patient, okay?
It will be interesting to know what was the consistence of the tumor.
It was coming easy to the section. Yeah, it was sectionable.
Interesting.
Could I ask, once you went transcallosal, what next? Did you go transforaminal? Did you expand? Did you take the septal vein? Did you just coagulate the choroid plexus back? What was your strategy after you went through, after you were in the ventricle, the lateral ventricle?
It was transcardial transfissure approach to the third ventricle directly. So
you opened up the fissure.
Yeah.
Okay.
Yeah, that's pretty good. Okay, congratulations.
So
Patient.
just
okay,
one more comment about the
Yeah.
EVD shunt issue. That might be a little ironic, but if you put an EVD initially, this patient would have never gone home with that. So would
Yeah,
have never been lost to follow up.
It's a good way to tie the patient to the hospital, right, Sammy? Yeah, that's what I would have done too, put an EVD and try to solve that problem as an urgent case.
Sorry, I have one more question. Is it possible?
Go ahead.
And
Yeah.
what are you going to do now with this residual part?
no, actually, it was blood. It was not residual. We have a follow-up, and the patient had an MRI. I couldn't have access. That's why I couldn't put in presentation. And the patient was it has been 1 year that we are following the patient, and there's no regrowth of the disease.
So
I'm
all this
sorry, I
part,
couldn't
all
put
this
the
part
MRI.
is just hemorrhage. All this part is just hemorrhage. Was
Yes, it was. We had afterwards an MRI, but I couldn't put it here.
yeah, it will be interesting to see MRI.
Yeah, I'm sorry.
No, that's
My
okay.
fault.
The was Dr. Zingberg involved in this case?
Yes, he was.
I'm trying to transfer him to a panelist here, but don't know, Dr. Zingberg, if you I'm trying to allow here. Yeah, if you want to just make a final comment since this is your patient, please give us a nice feedback and construction ideas. Are you muted now, Dr. Zingberg? Go ahead. Maybe having a little trouble with the.
Hi, Danny.
Hey,
Hey,
Dr. Zimberg, welcome. Give us the final words on this case, please, and before we move forward.
just coming in. I didn't hear.
Oh,
much of the
okay. I'm sorry.
Sorry. Sorry.
Yeah, it
for
was
that.
the Dr. Kim presented beautifully that you guys did a combined approach, endonasal and transcallosal for resection of this tumor. That
Uh-huh.
poor lady who had lost the husband with COVID and let the tumor grow here. Maybe if you just can mention how was your impression with the combined approach? Do you think was worth something you're going to do it again, or doing tandem one after the other? What are your thoughts about that type of
Yes.
technique?
We change our tactics. We don't want, especially on giant. We have plenty of giant pituitary adenomas. Now we move to these new tactics to approaching two approaches in a consecutive way, in order not to leave any residual, or at least very small residuals, because we in the past we had that nightmares with
Yeah.
big residuals in the ventricle. So from now on, we always try to use consecutive approaches, like
In the
this.
same anesthesia, right?
Yes,
Yeah.
in the same
Yeah.
anesthesia.
Yeah, that's what I do too. Yeah, I do an MRI in between, but we have the privilege of having that. And I guess if you don't have one, then you have to do what you got to do.
I have a question, Danny, to the panelists, if it's possible. Can we see the post-op with the hemorrhage? My question to the panelists is, I am a kind of afraid when I see too much blood, because in the past I have one patient with late vasospasm because of this hemorrhage. So for the panelists, question is, do you feel okay to let this blood inside, or do you feel better to go to take the blood out?
Yeah,
Our
let
team
me-
decided to watch the patient, monitor her a little bit more. So even though she were doing okay with the hormonal levels and no changes in cortisol or no DI, fortunately, with this mess, we we discharged her 5 days later, but we wanted to get her closer, even though she had the history that she lost follow-up, but we didn't go again to take out the blood.
Because she was
We
doing
didn't.
fine. Yeah. What do you think, Sadir, in India? If you see this like a little bit of blood on the suprasellar, are you aggressive to take patients back for this?
So if you have such a tumor, you have to do an immediate combined approach. That's what we follow now. You should do it in the same sitting, or you can do it. I think we all do in the same sitting because that has the best results. Rather than having a apoplexy and having problems with the hypothalamus and all that, it is better to do a combined approach if the upper part is not coming out. And if it is significant, like in this case.
But if you see the CT like you're seeing right now, let's say you do the combined, finish, get a CAT scan, and that looks like...
this would have required a combined approach because if you see the scans, it has multiple lobules which are going on the sides. And if you try to dissect them very aggressively, you are going to have some perforator infarct. So it is better to have a combined approach if you especially have lobules which are going on the sides.
Okay. But if you see this blood, like after the combined approach, then you do a CAT scan, there's a little bit of blood, patient is doing okay. Are you worried about vasospasm or you discharge the patient?
Yeah, we give nimodipine to these patients these days.
You do as well.
But we don't take that out, We don't take it out, but we'll give nimodipine to these patients. Yeah.
How about Jumuto? In Japan, you get a CAT scan and looks like that.
Yeah, just for us, so we can leave it and stay longer in the hospital and to see the patient as well, and to also check the hormone as well.
Okay, sounds good. If you all don't mind, I would like to invite Dr. Lamprecht to show the next case. Otherwise, we're going to be 1 hour in one case here, like we got to move. So Dr. Lamprecht has nicely from South Africa, sent his case for our discussion as well. So you can share your screen, Dr. Lamprecht, and then we'll go from there. Did he disconnect or all of a sudden? Or? I don't know what happened to him. David, do you know him?
Yes, I know him. He's one of my trainees.
Yeah, so do you want to maybe contact him, see what happened, if he's still alive?
I'm sure he's still alive. I'll give him a call.
You know, when the trainee is not available, then the trainer takes over.
Oh, he's back. He's back.
He's back, yeah. Dr. Lamprecht, do you want to share your screen?
Hi, my sincere apologies. I seem to have disconnected for a split second.
We noticed.
I apologize for that. Share my screen with you in a second. Screen. All right.
Perfect.
Are you all able to see?
Very well. Go ahead.
Yeah.
Right. Good morning. Good afternoon, everyone.
Go ahead.
Thank you very much for your time. I really do appreciate it. Again, I'm Matthijs Lamprecht from Neurosurgery at Tygerberg Hospital in South Africa. Fortunately, this is not an emergency case, as per our previous Rojtovsky, that I just wanted some advice on from the panel on how to approach this patient.
I think we're having a little bit of difficulties hearing.
Yeah, I think
seems to be a communication problem.
Is David there?
I'm here. I'm not with
You're not
Matthijs
with
now.
him.
No.
Do you want to?
I'm turning my video off to try and reduce any bandwidth problems.
Yeah, he disconnected. So maybe you can explain the case while we try to get him back.
Seems to have internet issues.
Yeah, poor man. Do you know the case, David?
I think we lost.
Can you hear me
David,
now?
so
Yeah.
David is muted.
David is muted. Dr. Lamprecht, you're back.
I can give you some background and
Yeah, go ahead, David. Explain to us why he tried to connect again.
So we have a 50-year-old female presents to her local hospital with a long-standing history of headaches. And these headaches are unresponsive to medication. She develops diplopia, particularly bad on left gaze. She's also developed discoordination. She's dropping objects, and she has some difficulty walking. Family and collateral give a history that she's struggling to pronounce words and not making sense from time to time. She has no background history of seizures or any other signs or symptoms. And these issues have been developing over the last 3 months. There we go. I see it's back.
Yeah.
Matthijs, do you want to take over?
Hi.
I think start on slide 3.
Sorry about that. Can everyone hear me?
Very well now, man.
Yes.
Okay. My sincere apologies. I don't know what's happening with our network. Thank you, Dr. Ratowski, for the summary. Essentially a 3-month history of worsening diplopia, deep-seated headaches, and change in her coordination, and her family mentioning her pronunciation and articulation is different. And then that's how she ended up in our system. Just her relevant clinical findings. She had a dilated left pupil up to 6 millimeters with very poor response to light stimulus. Her consensual reflex was, however, preserved. Her visual acuity was unaffected, and on confrontation testing, her visual fields were unaffected. Her formal VA and VF are still pending as an outpatient. She had a left-sided lateral rectus palsy with no other gross cranial nerve deficits. She had a dysarthria, a dysdiadochokinesia on the right-hand side, dysmetria, but the rest of her neurological examination was normal. So in summary, we're dealing with a left-sided cranial nerve 6 palsy associated with cerebellar signs, mostly affecting the right-hand side. Just going through the relevant imaging sequences, just to get straight to the point. On her sagittal, one can make out classical features of a meningioma extending from the clivus in the midline, displacing brainstem or midbrain and pons posteriorly, with some slight cranial extension, and involvement of various factors, which various other anatomical structures that I'll get into in a second. On the axial plane, one can make out some slight abutment of the fourth ventricle due to its displacement. Yeah.
And this is where is this patient right now?
She's currently at home. She's been discharged. She's coming back coming back to our unit for surgery, pending the decision at today's discussion. The one key thing I did want to show regarding this patient's imaging is in this slide, where one can see not only almost circumferential involvement of the basilar artery, but as well as encasement of both posterior communicating arteries. In summary, regarding her clinical examination, classical features of meningioma with no restricted diffusion and no blooming on SWI.
its superior margin, it extends into the suprasellar cistern. It abuts bilateral internal carotid arteries and displaces the optic chiasm left more than right. And as mentioned, it encases both PCOM arteries. Posterior displaces the midbrain pons with 270-degree envelopment of the basilar artery, and on the lateral aspects, it encases and thickens the left cranial nerve 6. The discussion for today and why I've decided to bring this case to the table is I require some assistance with the following questions regarding her goal for surgery. What are the targets for resection? The surgical approach, would the panel recommend an endoscopic transclival or a retrosigmoid with or without a Kawase or a subtemporal approach? Would you recommend it being staged or in a single sitting? What are the positioning considerations? And do you recommend any adjuncts or cranial nerve monitoring for this patient?
Yeah, while we discuss that, if you could go back to can you go back to the with contrast? Yeah, one of those. Yeah, this is good. We can leave it at the screen there. Dusik, what do you think, man? South Korea there, patient is home. What would you do next?
So I agree that we have two options. First one is endoscopy, endonasal approaches, because this tumor is not less involving the petrosal apex. The most of the tumors involve the clevus and cleval meningioma, and also I found that the T280 imaging is a very high signal intensity, and it means that tumor is relatively suckable tumors, and it's a good indications of endoscopic endonasal approaches. But the main problem my main problem is how to reconstruct after operations. This is posterior cranial fossa tumors, and it's very hard to reconstruct. And so, if you are not confident to the reconstruct after operations, and then maybe the retrosigmoid approaches may be better because it's also the suckable tumor.
Yeah, Suichi, what do you think?
Probably I would operate on this patient via left combined transpitosal approach.
Mm-hmm.
Well, like Dusik said, that the transnasal endoscopic approach is another very good option, but this patient is a 50-year-old, so we have to, secure their another 40 year. And so if you choose the endonasal approach, probably you can't take care of the whole dural attachment to repair the dura. So that's why I would prefer the combined transpitosal approach. That's probably guaranteed a gross total resection.
Yeah, very interesting. Francisco, I'm curious to hear your opinion.
To be honest,
try to be
until like 3 years ago, I will do it endonasal. But to be honest, in the end, most of the cases you need to combine then later with a retrosigmoid because you have to leave a little pieces. In this case, for example, in the left side. I think it's a good case for endonasal, but you have to be aware, and I'm agreed, the reconstruction is going to be a pain. And the time that you will spend in the surgery is going to be long. Nowadays, I am in a conflict when I see this kind of patient because I have a fine in my mind. I go endonasal and I go in a long surgery, or I do a posterior petrosal approach and take the tumor out. The last cases that I have like this, I am doing posterior petrosal approach, to be honest. Endonasal surgery in this case is going to be long. The reconstruction is going to have you some difficulties because you have more increase in CSF leak. You have to take care of a lot of issues in endoscopic, but it's a very good option. I don't abandon this option, but But I'm aware that it's better to go petrosal posterior.
Sami, I'm curious to hear your opinion as well.
Yeah, I mean, you have to think of this tumor in relation to the neurovascular bundle and what's the safest access without dealing with so many cranial nerves. And I know in Japan, the combined petrosal approach is very popular. If you look at that line that nicely drawn along the IAC, so you see that there is just a little tumor below that line, coming subtemporal anterior petrosal approach, it gets you direct access, lateral angle, where the basilar is on the back of this tumor. You have this luxury of looking a straight direct line behind the tumor and peel it off the brainstem, because that's your main goal here, is decompressing the brainstem. And when you come to the basilar trunk and you're seeing all these perforators, if you have an arachnoid plane and it's just pseudo engulfing of the basilar, that you can peel it off nicely in the arachnoid plane. If it's stuck, then you leave a shell of tumor on the basilar trunk. When we did the study that we published about the posterior petrosal with these cases, we found no advantage above the pontomesencephalic junction, which is the majority of this tumor is. So it gives you that narrow window through the facial and the lower cranial nerves to that anterior brainstem. And that's when we come endoscopic later, if we want to, like the patient is young and you have residual that is very central retroclival, then we would come transclival to get that part anteriorly to replace the posterior petrosal approach. If you think about retrosigmoid, I think retrosigmoid is the least favorable here. Is it a true petroclival meningioma? So you're going to be working through narrow windows through the nerves coming from a retrosigmoid to get there. Regarding the endoscopic by itself, I have to warn against the consistency of this tumor. We don't have really, we do the ADC map on these tumors and you can talk about consistency, but we haven't been successful. So going in endonasal first, you might deal with a very fibrous tumor. The basilar is on the back of this tumor. You have zero really ability to manipulate the line of sight to get to the basilar posteriorly, and the PCOMs, of course, on top. This patient have combined of 6th and 3rd nerve palsy, so there is some mass effect on the 3rd as well, on top of this tumor probably, because that's why the pupil is not that reactive rather than vision. So I think to summarize is anterior petrosal first, subtemporal anterior petrosal, and possible endoscopic for central residual.
Very good. Just to complement what you said, there's nice publication from the Mexican team where they show if you try retrosigmoid on these very retroclival tumors, you actually don't have a good space to really take it and correlate with higher level of morbidity for when that was attempted. But I'm curious to hear, Linda, you come from a center that the combined transpetrosal is really one of the main tools there. Like, what do you think, in your opinion, about just an anterior petrosectomy for a case like this instead of doing the whole pre-sigmoid?
It depends on the veins. So the two sequences that I would decide on this particular case would be the T2 sequence for a suggestion of the texture and consistency, the firmness of the tumor, and number two, the venous study. And especially the pattern on the floor, the orientation of a labet, the potential dominant drainage along the middle fossa floor, because there are situations, as you know, that the veins may be less favorable for either subtemporal along the left side or for cutting the tentorium for the petrosal approach. So the decision for approach for this case for me is wholly dependent on the veins. I agree that this could be at least to prepare for potentially a more firm consistency. Here, at least on the contrast scan, there's not the extra knobby tooth and sort of appearance that sometimes we see with the more invasive, invasive tumors. So if the T2 were favorable, meaning showing the suggestion of a preserved arachnoid plane, then it's really about the trajectory rather than thinking about the risks against the perforators. I think both, what Sammy said, or coming from the back, perhaps not even, because there's not really any extension of the tumor lateral to the tentorium in this case. So a pure posterior petrosal is a reasonable option here. And that gives you both the full skeletonization of the left transverse sinus to get that extra kind of straight trajectory going deep, as well as meaning the post, as well as so you could have a retrosigmoid window or a pre-sigmoid window, depending on what one wants, or the cutting of the tentorium to allow things to open up more. In these types of tumors, I guess, with a clival origin, the fifth nerve is probably pushed upwards. So that coming from the middle fossa, that fifth nerve you might encounter that first before the tumor. This person, I think, has a third and a sixth nerve palsy, from what I recall. He said there was a dilated pupil. So those, the sixth nerve, regardless how you come at it, from the back or from the front, will be, I think, quite involved. But the third nerve may be more, maybe more in the way a little bit, coming from the top as opposed to be the back. So I think, but for me, the decision of the approach, posterior petrosal or a different coming from anterior, would depend on the veins.
Yeah, I would like to mention that I agree with Sami with the idea that the pre-sigmoid, in my opinion, for this case doesn't help much, because you still have 7 and 8 in front of you, and you still have to work above and below 7 and 8, versus the anterior petrosectomy that you go from the top and you land it anterior to 7 and 8. I think that's what you meant, right, Sami? And then because there's no much inferiorly, I agree with you. That's, for me, that's the one of the main corridors there. And I want to hear from Jun Muto, because Jun Muto worked with Dr. Kawase for so many years. And what can you tell us, Dr. Muto?
Yeah, I think Professor Kawase will do the anterior petrosal approach only. Yeah, you can see the whole view. Yeah, I think so.
That's what you will do as well?
Yeah.
Good.
Let me excuse me, and let me just explain just one more. Okay, why I think we need the posterior transpetrosal approach view is that it's not easy to find the 6 nerves in some cases. So if we open the posterior, the pre-sigmoid dura, we can see the root exit zone of the 6th nerve, and then we can follow it. And that will, increase the safety of preserving the probability of saving the 6th nerve. That's my opinion.
And I agree. Is now I'm gonna throw one thing that I've been doing now that I want to see what you guys think. So I agree 100%. I have difficulties to find the 6th nerve when I do anterior petrosectomy only. It becomes difficult. I find it, but sometimes at the end of the case, and I do a little bit of blind dissection. So I realized that actually I can do faster combining anterior petrosectomy with the retrosigmoid approach. So instead of drilling pre-sigmoid that takes time, a very quickly retrosig allows me to do the same. So I also found the 6 deep there. As you go below the tumor, as I work below 7 and 8 from a retrosig perspective, and also to find 4 posteriorly. And then those things, it helps me to identify, not as the main tool to dissect ventral to the 5th nerve, but to identify the cranial nerves for safety as well. So I actually been adding a retrosig that is the position I put lateral anyways. I put the patient lateral, so a retrosig is right there, and a pre-sig pre-auricular. The anterior petrosectomy preauricular. So I combine a preauricular with a retrosig with 2 different incisions. I was doing with the combined, with a very curved, as we learned from a combined approach, but I realized you can just do 2. So for the last few cases, I combine anterior petrosectomy with a retrosig, which is, I think is a good option. And we've done a few cases with a good resection. I want to see just since we mentioned that Sadir is still there, would you do endonasal here, Sadir? I know you're a very good endonasal surgeon there. What do you think?
So what I will do in this case is I will do first, we go endoscopic, endonasal, drill out all the bone, take out the tumor. If it's coming out, it's well and good. Not coming out, leave the posterior capsule around, decompress as much as possible, wait for 4 to 6 weeks, and then go transpetrosal approach.
Yeah, that's what I would do probably too in my reality here, Sadir. I'll go because and I like the fact that T2 is so bright. And I think Lila, I think what would you go endonasal here as well? I know you're so skilled endonasal.
To my own opinion, for this case, the decision depends on which approach the surgeon is more confident with. So as we usually work like transnasal surgeons, we had just 4 cases like this, and we did them endoscopic transnasal endoscopic approach, but it was not a gross total removal of the tumor. So in this case, I think we will also start from transnasal transclavial approach, but of course with monitoring for certain sex nerve and maybe for caudal group, I think. And before the surgery, we will prefer to perform CT scans to understand the anatomic variations of posterior clinoid, because you have to do posterior clinoidectomy in this case, and it is important to understand do they have some connection with medial clinoid or anterior clinoid. So yes, we will start transnasal, but maybe later we will see what we will have, and maybe we'll ask our colleagues from posterior cranial fossa department to perform retrosig. Or maybe like in short hour cases, we can follow up the patients, and we can decide in future what to do if we have tumor growth or if we have no.
So now to finalize Dusik, I think we gave all the options, but I don't know if we helped the South African team there. We just spread the options through the fan. What would be your advice directly to Dr. Rojtowski and Dr. Lamprecht Dusik?
And I think
to put all together.
Not transorbital though.
Yeah, if possible, I'm gonna try to the transorbital approaches, but still, I think if the tumor consistency is important issues. Yes. But these tumors are very bright, fluctuated signal intensity, and I think that it's very good options for me to select the endonasal approaches. How about the Dennis? You try to the anterior pituitary or endonasal approaches?
Yeah. So I'll tell you my concerns on this case is actually the sixth nerve on the right side, the left side. It's what I'm more concerned with the endonasal. So what I would do is brighten T2, and because most of the tumor is retroclival, because for petroclival meningiomas, I look at the percentage. If a lot is on the petrous surface, I would come with a petrous approach. But if most is retroclival, I actually prefer endonasal. So here, my concern with the sixth nerve. So I open below the tumor, and I actually open the CSF space below the tumor. So I do a very, very large clivectomy. And I think it's important not to be worried about CSF at that moment, because you're more worried about the sixth nerve. Then I found the basilar in the back going behind the tumor, so I know the depth. If you open only on the tumor, you don't know the depth of the tumor, and you start debulking tumor without understanding the depth. So I like to see below the tumor, follow vertebral artery and basilar behind the tumor. And I also try to find the origin of six. Frequently, I see the six push down and ballooning below the tumor and not even through it. And that allowed me then to safely go and debulk the tumor. Superiorly, I agree with Lila. This needs a transposition. Usually I do a hemi-transposition in these cases. So most of the time I do on the left side because I do a hemi, and then my left hand, I can lift the gland with a suction, and I can actually do a dorsum resection and also a posterior clinoidectomy and go in the higher part of the tumor. Because if you go back in the sagittal, you see a lot of the tumor is behind the pituitary stalk. So it goes quite high there. So if you look at that right there, yeah, see how, so I would plan to mobilize the pituitary gland to go behind there. and I remove as much as possible, and then I agree with everything was said, and then my second best here will be probably in the surgery. I'm trying to remove everything, but if not, I want to make sure the lower part is removed, because as Sami said, then I can come with anterior petrosectomy for residual lateral on the left side. But if I have to do this without the endonasal, then I combine with the retro-sig, as I mentioned earlier. So I would say, now I guess what we should do is to hear from David. You know, if you have any other question, and Dr. Lamprecht, you know, what your thoughts, and do you think this was helpful, and let us know.
Just for the monitors part, because we haven't discussed that. So I would monitor 6, 7, and 8, and I rely on 8 for the bear, for the brainstem, just to give that also.
Yeah,
answer.
bilateral 6, right?
Yeah, well, if you're coming endonasal first, then you do
Yes.
bilateral 6.
Yeah.
But if I'm coming anterior petrosal first, then I would
only
do
it's
unilateral.
left. Yeah.
For the monitoring for this, if coming from a transcranial approach, I would monitor 3, 5, 6, 7, 8, and do cortical bulbars specifically for 3, V3, 6, 7.
Sounds complete. David.
Yeah, well, thank you. And Matthijs Lamprecht, thank you very much for putting this case together. As we see, the diversity of views shows the potential complexity, that there's no clear answer. I must admit my reluctance for an endoscopic approach here was because of my sense that this may be too firm a lesion to resect on top of a very difficult closure. Initially, I had an intention to approach this open cranial, predominantly through a petrosectomy, anterior petrosectomy. Given everybody's views here, I'm reconsidering that approach and considering whether the inferior aspect of it is better served with a transnasal approach and the clivectomy. But I'll have to keep you informed as to how we proceed.
And Dr. Lamprecht, do you have any other last thoughts in your perspective?
Not from my side. I think as Dr. Radowski said, the echo prioritize it gives credence to my question, but I found the input, especially the input on which nerves to monitor, very, very helpful. Thank you very much.
Yeah, no, thank you, everybody. I think since we're almost 10 minutes after the hour here, I'd like to thank everybody. I think this was very helpful, and I think the beauty of this group is that we try to really bring a reality to different scenarios, you know, around the world. What is available is not the same for everyone. I can see this being done in places where monitoring, for instance, is not available, or you don't have an ENT to work with you to help with the reconstruction. So all those things may change the way we make decisions in order to get the best results for our patients. So with this, I would like to thank everyone, and really appreciate all your presence today. We will get the recording from today, and we'll upload it in our YouTube channel. So thank everyone, and I'll see you next month. Thank you.
Thank you.
Thank you.
It was
a pleasure.
Thank you.
Bye.
Thank you.
Bye.
Goodbye.
Thank you.
Thank you very much. Goodbye.
Nice weekend.